Welcome to the weekly Neurology Deep Dive. Today, we're tackling a really important topic, long-term treatment for anti-NMDA encephalitis. It's a severe autoimmune condition, as you know. And just a reminder for everyone listening, this discussion is for educational purposes only. It's a summary based on specific research. We have no commercial goals here, and for the full picture, you really must read the original paper itself.
That's right. We're focusing today on the LEARN study, L-E-A-R-N. It stands for Long-Term Maintenance of Mycophenolate Mofetil in Anti-NMDA Receptor Encephalitis. It was published in the Journal of Neurology, Neurosurgery, and Psychiatry.
And our goal, as always, is to pull out the key insights from this research that might be relevant, directly relevant to your clinical practice as neurologists.
Exactly. Anti-NMDR encephalitis, it's devastating. High morbidity, even mortality.
And one of the big challenges, even after initial treatment, is relapse, isn't it?
Absolutely. That's a critical point. Current first-line treatments, things like IVIG, high-dose steroids, plasma exchange, they can be effective initially, but the relapse rates are significant. We're talking around 25, maybe 30% of patients.
Which obviously carries risks for worse long-term outcomes.
Precisely. And that's the gap the LEARN study aimed to address. Could maintenance therapy, specifically with mycophenolate mofetil, or MMF, reduce these relapses?
Okay, so tell us about the study itself. How was the LEARN trial designed?
Sure. It was a prospective study, multi-center, conducted across 4 academic centers in China. Importantly, it was randomized and controlled, although it was open label regarding treatment allocation. Patients and treating doctors knew who got MMF.
But the outcome assessment was blinded.
Yes, the people assessing the outcomes didn't know the treatment group, which adds strength. They enrolled 100 patients, age 14 and up, with acute anti-NMDA encephalitis. Key criteria were receiving first-line treatment within 2 weeks of coming to hospital and having a modified Rankin scale and MRS score of 2 or more.
So indicating at least some disability.
Correct. Then they were randomized. One group got their first-line treatment plus MMF 0.5 grams twice daily for 24 months. The other group just got the first-line treatment alone, the control group.
And the main thing they were looking for?
The primary outcome was the relapse rate. Also, time to relapse. Secondary outcomes included things like cognitive deficits, how quickly patients responded to treatment, specifically a 1-point or more improvement on the MRS within 4 weeks, and of course, adverse events.
Let's get to the results then. What did they find regarding those crucial relapse rates?
This was really the headline finding. The relapse rate was significantly lower in the group receiving MMF. Only 6% of patients on MMF had a relapse. That's 3 out of 51 patients.
Compared to
27% in the control group, 13 out of 49 patients. And that difference was statistically significant. P equals 0.006.
So quite a substantial reduction.
A very substantial reduction. The hazard ratio for relapse if you were taking MMF was 0.24, which basically means about a 75% lower rate of relapse during the study period for the MMF group. The Kaplan-Meier curves showed this clearly too, a much higher chance of staying relapse-free with MMF.
That's certainly compelling data on relapse prevention. What about that early treatment response you mentioned, the MRS improvement within 4 weeks?
Yes, they looked at that too. And again, the MMF group did better. About 84% of patients on MMF had that 1-point or more MRS improvement early on.
And the control group?
That was 65% in the control group. This difference was also statistically significant. P equals 0.03. So perhaps a faster initial recovery trajectory too.
Interesting. Did these early benefits and the reduced relapse rate translate into better overall long-term functional outcomes measured by the MRS?
That's where it gets a bit more nuanced. They looked at the proportion of patients with a favorable outcome, defined as MRS score of 2 or less, so minimal or no disability. At 12 months, it was 92% in the MMF group versus 80% in the control. At 24 months, 98% versus 90%.
Those numbers look better for MMF, but were they statistically significant?
They weren't, actually. The p-value at 12 months was 0.08, and at 24 months it was 0.11. So a trend towards better outcomes, but it didn't meet statistical significance in this study.
Okay, so relapse significantly down, early response better, but maybe not a statistically significant difference in overall favorable outcome score at 1 and 2 years.
Correct. However, they did find differences in other specific neurological issues.
Such as?
Patients in the MMF group reported less fatigue, less cognitive impairment, less depression, and fewer seizures over the entire 24-month follow-up period.
The seizure finding is quite concrete. Was that statistically significant at any point?
Yes. particularly at the 6-month mark. At that point, 77% of the MMF group were seizure-free, compared to only 53% of the control group. And that difference was significant, p equals 0.02.
So MMF might be offering benefits beyond just preventing major relapses, perhaps smoothing out the recovery and reducing those other common troublesome symptoms.
That seems to be what the data suggests. Another indicator of this was the need for rescue therapy.
You mean additional immunotherapy after the initial treatment and randomization?
Exactly. Significantly fewer patients in the MMF group needed rescue immunotherapy, only 6%, compared to 27% in the control group. That p-value was 0.006 again.
Suggesting better ongoing disease control with the MMF maintenance.
That would be the interpretation, yes.
Now, a key question for any long-term therapy, especially immunosuppression, what about safety and adverse events over those 24 months?
The safety profile looked generally reassuring in this study. Most adverse events reported in both groups were mild or moderate. Crucially, there were no deaths attributed to MMF, no anaphylactic reactions, and they didn't observe an increase in serious infections, neutropenia, or any tumors in the MMF group compared to controls.
So it appeared to be well tolerated for this 2-year duration.
Based on this trial, yes. And it's worth remembering MMF is also a relatively inexpensive medication, which is a practical consideration.
Definitely a practical point. So pulling this all together, what are the main practical implications for neurologists listening when they see a patient with new onset anti-NMDAR encephalitis?
Well, I think this study provides pretty strong evidence, level 1 evidence, arguably from a randomized trial, that adding MMF as maintenance therapy right after first-line treatment can significantly cut the risk of relapse. And beyond just relapse, it might also help lessen some of those persistent neurological problems, the fatigue, cognitive issues, depression, seizures.
And it seems reasonably safe for that 2-year time frame.
Based on these findings, yes. So it suggests you should certainly consider MMF maintenance therapy, particularly perhaps in patients you think might be at higher risk of relapse, though the study included a broad range.
To help us apply this, maybe remind us of some key inclusion criteria. Who are these patients in the LEARN study?
Sure, they had to have a new, acute onset of typical symptoms, psychosis, memory problems, speech issues, seizures, movement disorders, decreased consciousness, autonomic problems, even central hypoventilation within the last 3 months. They needed confirmed positive NMDAR antibodies in the CSF, age 14 or older, and importantly, they'd already received first-line treatment within 2 weeks of hospitalization.
And had that MRS of 2 or more.
Yes, MRS of 2 or more for at least 24 hours before they were assessed for this study.
And conversely, who was excluded? Any major groups we should be aware of?
Standard exclusions, mostly pregnancy or breastfeeding, active or significant infections, patients with pre-existing epilepsy unrelated to this, or other major brain diseases or trauma, also excluded if they tested positive for other relevant neuronal antibodies, or if they had an untreated teratoma, which we know could be associated.
History of cancer, too, I imagine.
Yes, history of cancer, recent major surgery, significant organ dysfunction, or, importantly, prior treatment with certain other immunosuppressants like rituximab or cyclophosphamide before entering the study.
Okay, that gives a good sense of the study population. So, wrapping up this deep dive on the LEARN trial, what's the bottom line for clinical practice?
The key takeaway is that long-term maintenance with MMF appears to be an effective strategy for reducing relapse rates in anti-NMDR encephalitis. It also showed promise in reducing some specific neurological deficits like seizures and maybe cognitive issues. Given its tolerability and cost-effectiveness, it's a strong contender for maintenance therapy.
But we always need to consider the context.
Absolutely. This is one important study, our randomized controlled trial, which is great, but it was open label for treatment. Further research is always valuable. Fully double-blinded trials, perhaps in more diverse global populations, would help confirm these findings and really fine-tune how we use MMF or other agents.
So, for neurologists listening, consider how this data fits into your management of patients with anti-NMDAR encephalitis. Does it change your approach? What further questions does it spark? We definitely encourage you to read the full publication in JNCP to grapple with all the details yourself. Thank you for joining us for this weekly Neurology Deep Dive.